So let's talk about malocclusions. And I'm concluding that in disease. Because remember, the car crash idea is what I kind of thought I was doing for the first half of my career. And that's not really what I want to do. But I'm going to show you a car crash first. Note the age on Ethan. Almost 11. He comes in, just think about what you would do with him in your practice. Here's what his occlusion looks like. Here's the crowding in the maxilla and the mandible, relatively mild on crowding. This is a patient a lot of us would just send out of our office because it's not that severe. Here's the pano that was sent over from the dentist. Anybody concerned yet? Canines are a little bit off course. In fact, they're a lot off course. So when did this happen? And all of us have dealt with impacted canines, and I used to love impacted canines. It was the time that I could prove I was hero at biomechanics, and I could get any tooth into the mouth, and I knew how to drive it in, and I loved it. Loved working with my surgeon. So these used to represent wonderful challenges to me. And in my mind, I always thought, oh, it's just a bummer that that patient got impacted canines, but I can fix them. Never really thinking why those impacted canines happen and whether or not they were preventable. I just thought they were something a certain percentage of patients got. But these are pretty tough. And so we have these procedures, expose and bonds, and you can get canines from the depths of the alveolus and you can pull them in. A case like Ethan, we actually had to pull straight buccal. This isn't actually a photo of him, but the expose and bond is similar. But we expanded Ethan like crazy, and we did traction on the canines directly buccal to get them out of the way of the lateral incisors. So here's how we finished up. The top 3 slides are what he looked like pre-phase 2. So all we did was get those canines into the mouth, because once they're in, I know I can drive them into their proper spot easily. I just don't like driving blind. So I try to get impacted teeth right into the mouth as quickly as I can. But you can take those crooked teeth and line them up and get nice occlusions. And so you can do your canine heroics. And again, these kinds of cases made me feel really good as an orthodontist, that I could control mechanics, that I could control tissue, that I could do surgeries with my surgeons. And when I look at his final case and I see that the roots of the lateral incisors are still long and they're well aligned and we've got good axial inclinations of the canines, and it makes me feel good that I can accomplish those things. Nice full profile, no extractions, wonderful. But that's a lot of invasiveness for this little kid. So I'm going to contrast it with Anthony. Now, Anthony probably taught me the most in the last 6 years, and he was a surprise. Notice Anthony's age compared to Ethan's. Anthony's a 1.5 years younger. And this is how he presented, not too different in terms of the crowding or arch form. You'll notice the maxillary lateral incisors are slightly blocked out, but it looks like they have adequate room. What I also want you to notice is there are no cross bites. This is just some mild crowding upper and lower arches. Some people would let this go. Many of us would image. The dentist happened to image, and they sent this pano over. Comparing him with Ethan, any big worries? I'll give you a closer look at those canines. Any worries yet? A little bit later, we took a cone beam. Probably 4 months later, here are the canines. I would not have expected that from the pano. But these, to me, are starting to look an awful lot like the previous case. And so having treated Ethan before Anthony, I thought, okay, here comes another one. But he's a little younger, so we're going to try and do everything that we can. But I'm going to talk to the patient and the parent about a future expose and bond, because I'm almost certain that's what we're going to do. So we went through the phase 1 consult, and I said, we're going to expand, and what we're going to do is we're going to take out the primary canines, because we know that helps change the eruption pattern of the permanent canines. and I'm going to expand the upper and lower arch. No braces at all because I don't want to run roots into erupting teeth. So this is all we did for him. We did a maxillary expander and a lower lingual arch, just gaining in the transverse, along with the extraction of the primary canines. So this is Anthony coming into my office on an observation visit. We let our patients go for a long time between phases. So he had 10 months of expansion, and then we took everything out and let him go. No retention. I just expanded him, stabilized. 10 months after, took everything out. So he's walking into my observation room, probably about a year and a half after that, and I'm watching him. And he's walking in, and I'm looking at him talking, and I'm thinking, that's a weird place for the first bicuspid. Or I'm thinking, I thought we ordered those baby canines out. Here's where the canines were. I didn't expect that at all. Some of you may have had these surprises, but this was a huge surprise for me. Getting in at the right time with relatively simple treatment redirected these canines in a very, very easy way. Now this is a very simple cleanup. Here's what the arch form looks like. You'll notice the width. You'll notice the uprighting of the lower molars. This is the pre-phase 1 and the pre-phase 2 record. What I want you to look at is the axial inclination of the maxillary canines. And if you just saw the T2 image on the right hand of the screen, your right hand, would you imagine that those canines were previously impacted over the lateral incisors? This to me told me that Mother Nature is so intent on getting teeth in straight that we just have to set up the system and get out of the way. If we can do that, and we figure out what it means to do that, we can do some pretty remarkable stuff with Mother Nature doing the hard stuff. And that's the more I practice, that's the more I want to do. I do less orthodontics now than I used to because I can see things coming a mile away. It makes mechanics a lot easier. Now, this paper was published about 2 years after I finished Anthony, and it explains almost exactly what I saw in him. Wonderful study out of Harvard, and it's a cone beam study on maxillary and mandibular skeletal width. Here's what the study did. They divided the sample into 5 categories. Normal controls, good axial inclination of the molars, what you and I know as unilateral crossbites, bilateral crossbites, what they call superior convergent, which is the maxillary molars are reaching out to the mandibular molars, poor axial inclination of the molars, and then finally on the end, inferior convergent, which I see very, very rarely. Now they measured skeletal width. That's what's so important about this study, and they measured it right in the coronal slice, and they measured how wide the mandibular bone was and how wide the maxillary bone was. Remember, there's a suture in the maxilla. There's no sutural growth in the mandible. If you look at these cases on study models, this is all you see. You can't see the axial inclination of those roots unless you have that coronal slice. So a normal control and a superior convergent, like Anthony, look very much the same on a set of study models. But if you look at the skeletal width measurements, what you'll find is the normals, the maxilla is about 1 millimeter smaller than the mandible at the skeletal. These are good, well-developing children. But notice the superior convergent, the patients with no crossbites had greater skeletal deviations than unilateral crossbites, and nearly as much of a skeletal problem as bilateral crossbites. And this was absolutely eye-opening to me. And it should be to all of us. And the conclusions of this paper I thought were brilliant. Patients without crossbites can have significant discrepancies that might warrant treatment. And I share this with all my pediatric dentists and all my referring doctors. Just because they don't have a crossbite doesn't mean they don't need expansion. And our pediatric dentists in the US are taught that crossbites need addressing, but if they don't have a crossbite and the crowding's not bad, they're probably fine. And a lot of those patients aren't fine. So when you look at how a case like Anthony treats out and compare his phase 2 to the previous case of Ethan, which would you rather treat in phase 2 if you had the choice? You'd probably want to go with Anthony on the bottom. And again, if you can avoid a trip to the surgeon, you'd probably want to do that too. And I'm almost certain that your patients would want to avoid that trip to the surgeon. Now, these become really easy cleanups. Using your appliances that work best in your hands, you can alleviate those deep bites and those crowdings, and you can get to really nice finishes in short periods of time. This is what he looked like when he was all done. Full set of dentition. Nice full profile. Airway healthy. So the way I see cone beam is it is a disease avoidance system. If you use it correctly and you see things coming a mile away, you can address them in a different way than you're used to. And I think we're going to learn a lot more about this as we get further and further into cone beam.